The treatment options really, in general, are based on several things. The disease itself and the patient age, performance, and comorbidities as well. And obviously, the long-term goal in those patients is still an attempt to cure the disease, which is only achieved most of the time with allogeneic stem cell transplant. So we are always asking ourselves, are those patients candidates for allogeneic stem cell transplant? Age is function, so one would consider transplant for patients as long as they are functional and they don't have major comorbidities that will prevent them going to transplant. The margin of benefit of transplant varies based on the age, and that's a discussion with the patient about whether they want to go to transplant or not. However, transplant usually is the second step, or the consolidation step, or the subsequent step. On the short term, we need to decide on how to treat those patients to get their leukemia into remission, because obviously the risk of relapse even after transplant is much less if patients go into the transplant when they are in remission. And even if patients are not going into, are not proceeding to transplant, going into remission has clinical benefit in terms of improving survival for patients, improving quality of life for patients. So the treatment choices currently we have are either the intensive chemotherapy or what we call the hypomethylating agents, azacitidine or decitabine. In general, azacitidine, decitabine had been used for patients that are, not candidates or not fit for intensive chemotherapy, whether they're, very old patients above age of 75 or 80, or those patients that have poor performance status, those patients that have renal, liver function impairments are treated with hypomethylating agents. They seem to be reasonable alternative to chemotherapy. In patients above age of 70, the outcome may be similar all over, but the chances of going into remission are less with those agents. In terms of the disease, there is emerging data that actually patients that have very complex karyotype, several chromosomal abnormalities, including what we call monosomies, or mutation, particularly in a gene called p53 mutation, that those patients may actually do better with hypomethylating agents than intensive chemotherapy. So we use hypomethylating agents in patients that have poor risk disease, especially the p53 mutation, or those patients that have a poor performance or cannot tolerate intensive chemotherapy. When we come to the intensive chemotherapy, nowadays we have actually a couple of options. We have the traditional chemotherapy, which we call the 3+7, which have been used for patients in the 60s, with different variations of the anthracycline used and controversy about the optimal dose of the anthracycline used. But in the past year, we had approval of a drug, which is the liposomal cytarabine and daunorubicin, that was approved for patients with therapy-related AML or MDS progressing to AML, or with AML with MDS related changes or karyotypes similar to MDS. So that drug is now used for that subset of patients, like the case we discussed is a classical therapy-related AML. So in case we are considering intensive chemotherapy, that would be probably the first choice in terms of intensive chemotherapy. Obviously, to put also in consideration, clinical trials are always probably an option for those patients. We always encourage patients to consider clinical trials because there is still room for improvement in the outcome for those patients.